Okay, imagine this. You reach for something on a high shelf, maybe just trying to comb your hair, and your shoulder just, it won't move. It's stiff, it's painful, and it feels like it's, well, slowly locking you out of your everyday life.
Hmm,
That frustrating scenario is exactly what millions of people experience with a condition often called frozen shoulder.
that's right. And today we're going to really dig into exactly what frozen shoulder is, how doctors figure it out, diagnose it, and most importantly, the non-surgical treatments that can actually make a difference.
Yeah, our goal today is really to break down the medical jargon and give you the most important takeaways. We're basing this on a brand new comprehensive set of clinical practice guidelines.
Right?
These were developed by a large committee of medical specialists in Korea, and they offer a really fresh perspective on this, well, surprisingly common issue. You might actually be surprised by some of what we uncover.
Definitely. So let's unpack this frozen mystery. Primary frozen shoulder is actually pretty common. It affects about 2% to 5% of the general population. And it's not just, a little stiffness. It's characterized by significant pain and a progressive restriction of both active and passive movement in the shoulder joint.
And that active and passive distinction, that's really key, isn't it?
Uh,
Active is you trying to lift your arm yourself,
right.
and passive means someone else, like your doctor, trying to move it for you. If both are limited, that's a pretty strong sign.
Exactly.
And who does this usually hit?
Yeah,
The guidelines mention it's more common in people aged, what, 40 to 65?
that's the typical range, yeah. And interestingly, females are more frequently affected than males.
Huh.
The condition also tends to sort of progress through three stages. First, there's a painful stage,
Okay.
then a stiffening stage where the movement really starts to lock up, and finally a resolution stage where things hopefully begin to improve.
Those can happen one after another or kind of overlap.
They can, yeah. Sometimes they occur sequentially, but they can definitely overlap in some people.
What's really fascinating, I think, is that even though it's so common, the exact reasons why it happens are still a bit hazy.
They really are. But the leading theories, they point towards inflammation within the joint capsule. That's the tough tissue around your shoulder joint.
Right?
And its lining, the synovial membrane. This inflammation then leads to something called fibrosis.
Fibrosis,
Yeah,
like scarring.
kind of, yeah. Think of it as the tissues inside your shoulder becoming thick and stiff, almost like internal scar tissue, making movement really difficult. And when they look at the tissue samples, studies actually show lots of immune cells, inflammation, and these fibrotic changes.
Okay, so that brings up a really important question that I know a lot of people have. Is it really self-limiting? The idea that it just gets better completely on its own if you wait long enough.
Ah, yes, that's the common belief, that it'll eventually run its course.
But here's where these new guidelines get really interesting. They emphasize a crucial point. Not all patients achieve complete spontaneous recovery. That surprised me.
It's a key clarification. Some people can unfortunately experience long-term issues, with symptoms sticking around for over 2 years.
2 years, wow.
Yeah, including stubborn limitations in the range of motion, reduced shoulder function, and, persistent pain. So it's definitely not always just a temporary thing you can ignore.
Absolutely not. And digging deeper into the why, these new guidelines highlight some truly surprising risk factors. There seems to be a strong metabolic connection.
There really does. It turns out that conditions that might seem, completely unrelated to your shoulder can significantly bump up your risk of developing frozen shoulder.
This is a huge takeaway, I think, like diabetes. If you have diabetes, studies consistently show your risk could be anywhere from, 1.3 to over 3 times higher.
That's right, a really significant increase. One study even noted that almost 1 in 5 frozen shoulder patients were using diabetes medication, compared to a much smaller percentage, like 7 or 8%, in people without the condition.
That's a stark difference. And it's not just diabetes, right?
No, thyroid disease also plays a role. Hyperthyroidism, specifically, seems to increase the risk. And more broadly, just general thyroid disorders, even things like subclinical hypothyroidism, where your thyroid functions are slightly off, are linked to an increased risk as well. The odds ratios are consistently elevated.
And there's more.
Yep. Dyslipidemia, that's basically an imbalance of fats in your blood.
Like high cholesterol.
Exactly. High cholesterol, specifically high LDL, the bad cholesterol, or even low levels of HDL, the good cholesterol. All these show a consistent link, suggesting you're more likely to develop frozen shoulder if you have these conditions.
So what's the bottom line here? What does this mean for someone listening?
Well, the consistent link between these common metabolic conditions, diabetes, thyroid issues, dyslipidemia, and frozen shoulder, suggests it's really critical to look at your overall health, not just the shoulder in isolation.
Right, a holistic view.
Exactly. Understanding these connections can help your doctor give you a clearer idea of your prognosis and maybe tailor a more effective treatment plan. It's a powerful reminder that your shoulder health isn't separate. It's really connected to your body's broader metabolic state.
Okay, that's fascinating.
Hmm.
Let's shift gears to diagnosis. This is where it gets interesting for anyone who thinks, oh, I need an X-ray or an MRI right away. The guidelines seem pretty firm here.
They are. They state very clearly that the diagnosis of frozen shoulder is primarily clinical,
Meaning?
meaning it's based on your patient history, what you tell your doctor about your symptoms, how it started, what makes it worse, and a thorough physical examination. That's where they assess both your active and passive shoulder movements.
So that raises the question then. If it's primarily clinical, what about imaging, like ultrasound or MRI? Do you even need a scan?
That's a great question. And the guidelines are quite specific. Ultrasound is not recommended as a standalone diagnostic method.
Okay.
Not on its own. Right. Think of it more as an adjunct tool. It helps, but mostly for ruling out other conditions that might look like frozen shoulder, like a rotator cuff tear, for example.
Got it.
Ultrasound can sometimes pick up subtle changes like thickening in certain ligaments or the joint capsule in the shoulder, but there's a lot of variability in interpreting these findings. And it really depends on the skill of the person doing the scan.
And MRI? Is it
Yeah.
similar?
Pretty much, yeah. MRI is also not recommended alone for diagnosing frozen shoulder. It's more useful for differentiating frozen shoulder from other shoulder problems, maybe helping understand the stage of the condition.
It can show things like inflammation.
It can, yeah. It might show thickening or inflammation enhancement, they call it, in parts of the joint capsule or the rotator interval. But just like ultrasound, there's significant variability in how accurate it is on its own for just diagnosing frozen shoulder.
So the big takeaway here seems to be that imaging helps support a diagnosis or rule out other things. But it's your doctor's clinical assessment, listening to you, examining your movement, that's really the most important piece.
Precisely. It's less about what the scan shows in isolation and much more about how the entire clinical picture fits together.
Makes sense. Okay, let's move on to treatment. What non-surgical options are out there? The guidelines seem to cover quite a range.
They do. They review a whole spectrum, from physical therapies and exercises to different kinds of injections. This is where we can really see what the strongest evidence supports.
All right, let's start with the things that have good evidence, the stuff they say, yeah, consider this.
Okay. First up, electrical stimulation therapy. Things like 10S units. These could be considered specifically for pain relief. Studies showed it can provide pretty immediate pain reduction and might even help a bit with recovering range of motion.
Good for pain. What about hands-on stuff?
Manual therapy, which includes things like joint mobilization and targeted range of motion exercises performed by a therapist, is another one. This may be considered for improving overall upper limb function and shoulder ROM.
Okay, getting the movement back. Now, what about injections? I feel like that's something people hear about a lot.
Yes, and for good reason. Intra-articular steroid injections, meaning steroid injected right into the shoulder joint, are highly recommended.
Highly recommended. Okay.
Yes. They should be strongly considered to significantly improve both shoulder pain and upper limb function.
And what's really interesting, you mentioned this earlier, is combination approach.
Exactly. The guidelines highlighted that a combination of these steroid injections and physical therapy showed even greater benefits for pain and function than just doing physical therapy alone. That really points to a multi-pronged strategy being effective.
Now, does it matter how the injection is done? Like with ultrasound guidance versus just based on landmarks?
It's a common question. While using ultrasound guidance can definitely be more accurate in making sure the needle is perfectly placed. The studies reviewed didn't actually show a significant difference in the clinical outcomes, meaning pain relief or functional improvement, compared to landmark-guided injections, provided they were done by an experienced clinician.
Ah, so the experience of the doctor matters a lot.
It does. The decision often comes down to the clinician's expertise and comfort level.
What about the dose of the steroid? Is more better?
Well, the guidelines point out there isn't quite enough evidence for a definitive recommendation there. For example, comparing a 20 milligram versus a 40 milligram dose of triamcinolone, a common steroid.
Okay.
While the higher 40 milligram dose might offer slightly greater improvement in function and ROM, the doctor has to weigh that against potential, though usually temporary, side effects like facial flushing or a brief spike in blood sugar, especially important for diabetic patients.
So it's really a clinical judgment call.
Exactly, left to the clinician's judgment based on the individual patient.
Okay, any other injection-related therapies? What about hydrodilatation?
Yes, hydrodilatation. That's where they inject fluid, usually saline sometimes with steroid, into the joint to physically stretch out that tight capsule. The guidelines say this could be considered in conjunction with the intra-articular steroid injection.
So maybe doing both?
Potentially,
Okay.
yeah. It showed significant added benefits for pain and function when combined with the steroid.
Interesting. And what about nerve blocks?
Yeah.
Like a suprascapular nerve block?
That's another option, primarily for pain relief. It could be considered. Studies showed it provided significant pain reduction in the short and midterm,
Okay.
and even some improvement in upper limb function midterm. But it's important to note, these studies compared it to things like physiotherapy, not directly head-to-head with the intra-articular steroid injections.
Ah, okay. So maybe good for pain, but not necessarily instead of a steroid shot.
That's a fair way to put it. Consider it for pain, but steroid injections seem to have broader evidence for function too.
Right. Let's talk about the treatments where the evidence is maybe a bit less clear or where the guidelines say use clinical judgment.
Right. This is where things are less strongly recommended. For example, deep heat therapy things like therapeutic ultrasound for heating. There's just insufficient evidence for its effectiveness. So use is really based on whether your clinician thinks it might offer some benefit in your specific case.
Okay. What about taking pills, like oral steroids or NSAIDs?
Yeah, oral steroids taking steroid pills by mouth also have insufficient evidence for a strong recommendation. While some studies showed they might reduce pain initially,
Mm-hmm.
those effects might not last, and you have to consider the potential systemic side effects, like effects on bone density, blood sugar, or even stomach issues.
Right. More risks potentially.
Exactly. And oral NSAIDs like ibuprofen or naproxen, they may help reduce pain and improve ROM a bit, but again, insufficient evidence compared definitively to other treatments. So for both oral steroids and NSAIDs, it's really up to the clinician's assessment and weighing the pros and cons for you.
What about exercises the patient does themselves, like self-stretching?
Self-stretching exercises are important, yes. They can be considered as an adjunctive management strategy.
Meaning alongside other treatments.
Precisely. But the key is proper exercise prescription, knowing exactly how to do them safely and effectively, and patient adherence, actually doing them regularly.
Makes sense.
While no direct evidence showed self-stretching was superior all by itself, studies did link daily self-stretching to improved ROM and potentially shorter recovery times when combined with other care.
And strengthening exercises.
Similar situation. Shoulder strengthening exercises may improve pain and functional recovery, but because there aren't many high-quality studies specifically on this for frozen shoulder, implementing them is again based on clinical judgment when the shoulder is ready for it, which exercises, etc.
Okay. Any other injections to discuss? What about hyaluronic acid, sometimes called HA or joint lubricant?
Right? For HA injections, the guidelines generally prefer intra-articular steroid injections first. They seem more effective, especially short-term.
But if steroids aren't an option,
Exactly. If a steroid injection isn't feasible for some reason, maybe due to diabetes control issues or patient preference, then hyaluronic acid injection may be considered based on clinician judgment. It was less effective than steroids for short-term pain and function, but it still showed improvements compared to baseline. So it's an alternative, but maybe not the first choice based on this evidence.
got it. Okay, one last one, and this sounds a bit more intense. Manipulation under anesthesia or MUA?
Yeah, MUA. This involves the doctor forcefully moving the shoulder through its range of motion while the patient is under anesthesia to break up adhesions.
Sounds dramatic. What do the guidelines say?
The guidelines are quite cautious here. They state it has insufficient clinical evidence to strongly support its effectiveness. And importantly, it carries significant risks of complications.
Like what?
Things like fractures of the humerus bone, rotator cuff tears, nerve injuries. Pretty serious potential downsides. So therefore, the guidelines strongly recommend that intra-articular steroid injections should be considered before even thinking about MUA. It's seen as a procedure with notable risks and not enough proven benefit to be a go-to option.
That's very clear. Okay, so let's try and wrap this up. To recap our deep dive today, frozen shoulder is clearly, well, it's more than just a stiff arm. It's got these surprising and strong links to your overall metabolic health, things like diabetes, thyroid issues, and cholesterol problems.
Absolutely. Your whole body health really plays a role.
And while it can be really stubborn, these new guidelines show there's actually a strong evidence base for some effective non-surgical treatments, especially those intra-articular steroid injections,
Very highly recommended.
particularly when they're combined with physical therapy or perhaps hydrodilatation.
That combination approach seems key for many.
And crucially, remember that the diagnosis comes primarily from a good clinical exam with your doctor. Imaging like ultrasound or MRI, they play a supporting role, mainly to rule out other things, not as the standalone answer.
Couldn't have said it better. The clinical picture is paramount.
So if we connect this to the bigger picture, these new guidelines really seem to underscore the importance of looking at the whole person, that comprehensive assessment, and creating individualized treatment plans. It's moving away from a one-size-fits-all approach for frozen shoulder.
Exactly. Your personal health profile, including those metabolic factors, really matters in how we approach this condition.
So for you listening, this kind of raises an important question, I think. How might understanding this interplay between your overall health, your metabolic well-being, and a specific physical condition like frozen shoulder, how might that empower you to be a more active, more informed participant in your own healthcare journey? Something to think about.